Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation. Just hold your thought. There we are. I just want to make sure we're live. Let me just expand our video here. I'm going to check to see if it's popped up on my phone so I know we're here before I make our introductions. I'm not seeing it yet. Let me go back out, come back in, and let's see if we are there. Yes, we are there. So we are there. Welcome to the March 2024 Vascular Birthmarks Foundation's Facebook Live. I have a new VBF expert, and we're all very excited to welcome Dr. Naiem Nassiri. He is from Greenwich, Connecticut, formerly with Yale at Yale. Also spent time with Dr. Rosen, one of our all-time favorite doctors at Lenox Hill in New York City.
Correct.
He is very unique because in our entire world of VBF, we don't have a vascular surgeon who also does interventional work. So that makes you special. So welcome to our Facebook Live.
Hi, everybody. Great to be here.
And just let me know right now that, I'm saying too low, but that's all right. I'm sure that's fine. Let me know that you can see us. Oh, I see there's 9 people on already. Dr. Nassiri will be answering any questions regarding vascular anomalies. He is developing so many new techniques for treating venous and lymphatic and AVM and May-Thurner, which we're not really calling anymore, but still, especially Klippel-Trenaunay syndrome, but mostly anything extremity, anything other than in the brain, basically.
Correct.
Is what you can do. And even then, you can send those people to somebody.
Yeah.
We know somebody, right? So let us know. Oh, sorry, we've got them coming in. Sorry, I gotta turn the volume down. Oh, hi. So let us know where you're from and then ask your question. So, hi Deb, hi Ava, hi Gina. It's great to see you all. Emily says, hi Dr. Nassiri, nice to see you here. Emily Sanchez Giuliano.
Yes.
Hi Juliet, hi Patrina. So, one of the things is all of you who are coming to our free super clinic in October, Dr. Nassiri will be there. So he will be joining. I'm not sure if he'll be on Dr. Rosen's team or the surgery team, or he may spend time on both.
Yeah, that's a good
It'll be
idea.
up to you, whichever you want to do. So I see quite a few of you are on. Remember, ask your questions. Look, if we can't answer them, we'll figure out a way to get the answer back to you. And Gina is on, and Gina, you can post Dr. Nassiri's email, and you can post my email in the comments section so that if people do want to reach out to him, they'll have his email. His office is in Greenwich, Connecticut, and it's called the Vascular Care Center,
Correct.
and it's multidisciplinary. And what are some of the things you treat besides vascular anomalies?
Well, I'm a practicing vascular surgeon, so I practice the entire gamut of vascular and endovascular surgery, and our treatment algorithm ranges from everything from open surgery to really the non-invasive and minimally invasive therapies, and then hybrid procedures which encompass both open surgery on blood vessels as well as essentially medical management and minimally invasive therapeutic approaches. We actually have 2 offices in Connecticut. We're a very large group. We span 3 states of Connecticut, Massachusetts, and Maine. And we just opened up our 2nd office in Stamford, Connecticut, in addition to our office in Darien. So we're the largest and most rapidly growing private practice group in the United States.
Wow, and tell the good news about accepting insurance.
We do accept insurance.
And you're good at the billing and coding, so we know
Absolutely.
that that's a big concern from a lot of our families. So once again, I see a whole bunch of you are on, and we can take your questions. A lot of times they want to hear who you are and what you do. One of your specialties is extremity lesions.
Correct.
What are the current typical, not what you do, but in the mainstream, what is a typical approach for treating Klippel-Trenaunay of the extremities?
Yeah. So Klippel-Trenaunay syndrome is within that sort of broader spectrum of PIK3CA related overgrowth syndromes. We now, as you know, Linda, better than anybody else, we now really have a genetic roadmap that's fairly reliable for understanding the causes of a lot of these malformations, be them syndromic cases like Lipotrenane or sporadic lesions, which are, you know, malformations that are happening in isolation. So being KTS being part of that broader sort of umbrella of PIK3CA related overgrowth syndrome typically is associated with a clinical triad, and that involves having capillary malformations, the so-called port-wine stains, underlying low-flow vascular malformations, right? I won't call them specifically venous or lymphatic, and then having some sort of a asymmetrical hypertrophy, not hyperplasia, but hypertrophy of an affected extremity, and that can affect sort of any part of the body. But one of the most underappreciated phenomena that takes place in Klippel-Trenaunay syndrome is what we call in medicine pathognomonic, which means if you have it, this is clearly a telltale sign that you have this problem, is the presence in 20% of patients of the term that I like to call the lateral marginal vein. And this vein has been misdiagnosed and has been called all kinds of things, and persistent embryonic vein, or the vein of Serval, who was a French surgeon, who was really one of the first to kind of talk about it. But the essence of Klippel-Trenaunay syndrome, if you really boil it down to simplistic terms, is the presence of venous hypertension, multifactorial, be it as a part of the venous malformations that are happening all over the affected limb, or as a result of a lot of the venous compression syndromes that would have been otherwise dormant but are now becoming apparent and symptomatic and causing problems. And so there's a whole algorithmic approach to KTS. It looks intimidating at first, but once you break it down into its individual components, it's actually a highly treatable disease that can really give the patient a good quality of life.
That's wonderful, and I know there's some things coming down the pike that we're both excited about.
Yeah.
I don't know what you can say about that.
Yeah.
Can you give a little bit of a teaser?
Sure, yeah, Dr. Linda is referring to really innovative inventions and patents that I filed through my affiliations with colleagues at Yale. You know, we are now going into a pathway where we are going above and beyond what traditionally has been offered in terms of sclerotherapy or embolization, or what you want to call it. You know, traditionally we have been using basically agents that had grandfathered themselves into the armamentarium of the interventionalist or the surgeon who was basically injecting or embolizing in a very sophisticated manner. I mean, my mentor, Dr. Rosen, is really world-renowned for really advanced you know, techniques in terms of delivering these sorts of agents into the malformation. But we had traditionally been using basically irritants, right? That's the mainstay of treatment. You inject the lesion with some sort of an irritant, be it ethanol or glue or other what we call polymerizing agents or detergent-like compounds that are just irritating the lesion. But we're going one step above and beyond because we now have a genetic roadmap. Why don't we go ahead and deliver focally into these lesions medications or compounds that counteract exactly what's going on and what's caused the malformation in the first place. And there's lots of science that we can deduce from the cancer realm. There are technologies such as nanoparticles, which are really advanced formulations that find their way directly into where the disease is. All these things can sort of be combined and thought of in a sort of a hybrid approach to deliver treatment in a manner that goes above and beyond what we have traditionally done. So that's just one teaser, and there's a couple other things that I'm sure we'll touch on a little bit later on during the interview.
Yeah, I'm so excited. I mean, just when you think we're saturated, new things come out that really make me all excited all over again about being in this world, because I get so frustrated when I see the kids suffer or the adults suffer, and they post all the time about their pain, and or they've been misdiagnosed. Like you said, so many people use different terms. Then if you use the incorrect term, you're going to have the incorrect therapy. Then they come back and say, why did this happen? And I'm like, okay, well, you were misdiagnosed.
Right.
And unfortunately with vascular anomalies, that's quite common.
Right. I think we have a question.
Yes, first of all, Jody said that was the best breakdown I've ever heard about KTS. Thank you. She said, do you have any thoughts on this type of injectable for a lip port wine stain? Because we talked about, remember that's an overgrowth?
Absolutely. So that's a great point, and I think this goes back to Dr. Linda's sentiments just now about how critical it is to make sure that we have the right diagnosis, right? And so it is very important when we talk about port wine stains, whether we're talking about capillary malformations, which is what they are, by themselves in isolation, and if there is overgrowth deep to this, is there any sort of underlying vascular anomaly that is deeper within the port? We know port wine stains can happen with fast flow or high flow arteriovenous malformations. We know that they can resemble angiokeratomas that can overlie venous malformations and or lymphatic malformations. We know that it can be associated pathognomonically or characteristically with entities such as Klippel-Trenaunay syndrome. So to answer your question, it really depends on what we see deeper to the port wine stain. And one of the most underutilized diagnostic modalities, believe it or not, for diagnosing and classifying vascular malformations is the good old what we call duplex ultrasound. And duplex, right, gives you three pillars really of information. Number one, it actually gives you an ultrasonographic outline and contour of the lesion, or the so-called angioarchitecture of the malformation. Number two, you can turn on, and that's called, the first one is called B-mode imaging. The second component is what we call color flow Doppler, and that's when we actually can detect flow within channels of the malformation. So that's number two. And then number three, this is where it gets a little bit more sophisticated, is what's called spectral waveform analysis. And based on that spectral waveform, right, which is just the pattern of blood flow, we can not only detect how fast blood is flowing, we can actually calculate flow volumes, so we can detect how many liters of blood per minute, for example, is flowing to the lesion. And most importantly, we can characterize the flow properties, and based on that, we can give a very specific diagnosis of exactly what's going on. So that question is best answered by saying that it depends on the subtype, and if there are malformations deeper to the port wine stain, and it's not just a mere soft tissue hypertrophy, then there are absolutely embolotherapeutic options for delivering biomolecularly active agents into the malformation.
Well, I know her daughter had the ultrasound by Dr. Coletti, and he said it was pure capillary malformation, but that's what I was talking to you about, the project Dr. Mim and I were working on, where it looks like pure capillary malformation, but it has this overgrowth factor.
Yes.
So there's still something, you know,
Absolutely.
we just don't know.
And I would actually argue that, you know, if we do DNA sequencing on that port wine stain, I would be very interested to see what sort of DNA sequencing results we're going to get, because that is essentially the hallmark of what we call PIK3CA related overgrowth syndrome.
What kind of would that be? Would that be a tissue, blood, or urine analysis?
It would actually be a tissue.
Okay.
Which would include the port wine stain.
Okay, well, I'm only saying that because I know a lot of the moms would like to know it, but I don't know that they want to have a piece of tissue taken out.
It actually can be done in a fairly cosmetically, friendly way.
Right.
If need be.
Right,
and
right.
we can do it's doable, but the amount of information that gets back to us is tremendously helpful.
And one of the things Dr. Comey found out, our Sturge-Weber expert, when they were doing the testing, is there is a certain location you have to get the biopsy from, otherwise you're not going to get an accurate reading.
Correct.
So
as long as you have the malformation,
right.
then you can, and then you would need some saliva specimen to compare. It's called paired exome sequencing.
Beautiful. So Patrina writes, from New Zealand, I have identical twin boys. One of my boys was born with a port wine on the left side of his face. My boys are nearly 4. Okay, Patrina, what is your question? So maybe it's because they're identical.
Huh.
Because that is unusual. One placenta?
Well, yeah, one born with port wine. Well, one born with port wine stain, and we're not talking about, for example, a hemangioma. So that kind of renders merit to the fact that these are what we call somatic mosaic gene mutations. It's not mom's fault. Mom didn't ingest anything during pregnancy. This is just some switch that happened to go off. And case in point, one twin, which shares identical DNA, just happened to have the switch go off in some sort of environmental milieu, either in utero or right after birth.
That's what we're telling everybody, or explaining the whole germline versus somatic, so that the parents have that freedom of knowing they're not gonna have another child.
Correct.
Likely not, it's the same statistical probability of having one
Correct.
as the second. Farouk says, can tinnitus be associated with a facial Sturge-Weber syndrome?
Absolutely. I mean, it just depends on the extent and nature and the penetration of an underlying vascular malformation. And so these things are so idiosyncratic. One thing that we learn about malformations is really they have no respect or rhyme or reason for anything. These are highly idiosyncratic lesions. They have their own very unique manifestation in each individual patient. So one cannot make a blank statement to say, no, absolutely, it's got nothing to do with it, or yes, every single case is associated with it. There's a very high likelihood that there certainly can be an association there, but again, you'd have to really dig a little bit deeper to understand exactly what the cause is in that individual patient and do the proper workup.
And there's been a lot of talk with various lesions, especially port wine, about what we call patterns of predilection.
Mm-hmm.
Is it a pattern of predilection though, or is it a statistical probability that it's gonna occur, and they think it's a pattern because left eye, right eye,
Right.
you know, or with 0.03, with 4 million babies born a year, aren't we gonna start seeing
Yes.
them, right? So, who knows?
You have a very forward-thinking sort of approach to this. It's very AI-based. So let's put it to the AI
Yeah,
and
let's
see what
do-
it says. I think we're going to get a lot of information based on AI. There could very well be a mathematical model for predicting. You're absolutely right. But I guess we're not there yet. We're not sophisticated enough just yet, but soon enough.
I like that, oops, sorry. Again, we're here with Dr. Nassiri, and these are great questions, and we see that you're calling in from all over. We have a new one from Jill. Hi, Jill. Are there any treatments for people who are missing deep veins in their legs, or suggestions to preserve her superficial veins? My daughter is missing her femoral and popliteal vein.
We were just talking about that, weren't we? So it's a very good question. I think one of the biggest myths in the realm of vascular malformations is that patients with Klippel-Trenaunay syndrome have missing deep veins. And so folks are very hesitant to treat the lateral marginal vein or the superficial veins that actually may be incompetent and refluxing, or they may be hesitant to treat the sort of what we call more cranial, the parts of the veins that are closer to the head, right? Or the pelvic region or the belly. In what appears to be quote unquote absent deep systems, right? Femoral popliteal veins. These veins may very well be present, but they are dormant. They are what we call, they have hibernating lumens. And once you direct patterns of blood flow away from the incompetent superficial veins, be them malformations or actually like veins such as the great saphenous vein or the lateral marginal vein that are refluxing, you will redirect blood channels. Whenever there's a propensity for flow, new blood channels will sprout and develop. We see that all the time in vascular surgery. That's why it's very important to have a vascular surgeon who has a good understanding of these things. But you are never going to be deprived of veins. So one should never be afraid of treating an incompetent vein who's not doing its job because we're afraid that there is an quote unquote absent deep system. And so yes, it may be a hibernating deep system. It may be underdeveloped, but so long as there's arterial flow bringing blood down to the extremity, the blood will find a way to take it back up towards the heart. We are designed that way. So you will never have a situation where your leg, God forbid, is blowing up because you decided to treat the underlying venous malformation or any other venous hypertension related issues pertaining to the pathology affecting that extremity.
It's excellent. Carrie Frederick says hi from Charleston. My grandson has a vascular malformation. He had an MRI at Duke, and they said venous malformation, low flow. They don't recommend treatment at this time, and I wonder why. It's very close to his eye.
Great question. I would absolutely recommend treatment, especially if it's sitting near a critical organ like the eye. And I don't know how old your grandson is, but if it's sitting that close to the eye, 100%. And just want to clarify something. There is no such thing as high flow or low flow venous malformation. Sometimes this gets lost in the confusion. A lot of the physicians actually get confused about this high flow, low flow, and they think there's such a thing as a high flow venous malformation. That's not the case. By definition, a venous malformation is always, without exception, low flow. Now, if it's near the eye, I would 100%, 110% recommend treatment as soon as possible, because if this thing continues to grow, and it will, but it doesn't grow like we've seen, for example, with infantile hemangiomas, it doesn't have this sort of relatively predictable, gradual pattern of growth. Everything will be fine, and then one day you'll wake up and it's blown up because there's some sort of an environmental trigger, or there are fluctuations in the hormonal milieu that act like fertilizer for these things and will cause them to abruptly become problematic. My motto for malformations is I'd like to stay ahead of these things before they become a problem. I don't want to wait until it's a really blown up serious problem, and now I'm playing catch up. Me and the patient and the patient's family are playing catch up with the lesion. I like to stay ahead of the lesion. So get this treatment and get it done as soon as possible.
And so I want to say to her, because she's asked another question.
Sure.
Dr. Nassiri's email is in here, and he's very happy
Absolutely.
to take a look at any records you have or photos. Also, very important, if you come to our super clinic in October, you can see him in person. Dr. Coletti will be there, so they can be together to do the ultrasound, and you can get a really good assessment, or you can come way before that and start talking to him now, because he's 2 years old. The little boy, the one that has the venous malformation.
Oh yeah, I would
diagnosed.
100% get it treated as soon as possible. I think she had a couple of questions, follow up.
Yeah, it enlarges and gets swollen when he cries. Typical venous.
Classic venous malformation.
Tip him upside down
Absolutely.
and you'll see
Yeah,
it.
absolutely.
Jill Kitson said, with MRI suggesting that there are no veins, should we see someone for some kind of treatment, or just let the superficial veins that are becoming dilated do what they're going to do?
So I think what you're referring to, and you have to be very careful. I mean, I got to tell you, there are just such select few centers in the country that, again, this is not a criticism of anything or anybody, but just sort of collective understanding of what exactly is going on is incredibly rare in the United States and even globally. So I would recommend kind of reaching out to Dr. Linda and having one of us and sort of the foundation kind of take a look at this thing. I think what you mean is that they did not find a significant, what we call venous tributaries or connecting the malformation to the deeper systems that drain the head and neck. I think that's what you're referring to. And so if that's the case, and the lesion is more or less an isolated cluster, then my recommendation for a first to go maneuver would be embolization to devascularize the lesion. Now, in lesions that are very close to the eye, you have to have a very detailed angiogram and venogram to decipher exactly what is the feeding and potential draining patterns are for that particular lesion. The other thing I want to tell you is that please make sure you've characterized this with a duplex ultrasound. So MRI alone may not always be, and it has to be a T2 fat suppressed series, but MRI alone may not be adequate enough to distinguish between an arteriovenous malformation and a venous malformation, especially in a tiny 2-year-old. So I would strongly recommend getting what's called a hockey stick probe and getting a very sophisticated vascular specialist, a vascular doctor, to oversee a highly specialized vascular technician to do a duplex ultrasound and characterize the lesion definitively. And then based on that, we can then proceed with embolization to devascularize the lesion, and follow that by surgical excision and local reconstruction should it be necessary. In general, I like to combine the two. I don't like to go with one modality only versus the other. And again, that's why it's important to have multifaceted doctors taking care of this, because if you're a hammer, everything you see is a nail. So if you're a surgeon and you like to cut, well, you're going to offer cutting to everybody. If you're just an interventionist, you're just going to offer intervention. So it's important to be multifaceted and to see someone who is able to offer you a variety of different treatments that is tailored specifically to your pathology.
And Carrie, he practices, it's near Stamford, Connecticut, at the Vascular Care Center. He was at Yale and in New York City. Again, his email is right there in our comment section, or you can come and see him in October at the Super Clinic in New York. You even get free lodging, free ultrasound, so forth. Tiffany has a 2-year-old son with a port wine stain on the left side of his face, his nose, his cheek, and upper lip. Once we reach maintenance phase, is it worth continuing regular laser just on the upper lip to try and limit the hypertrophy?
I think it's, if it's working for you, that's absolutely a reasonable approach. Again, I just want to make sure that you have ruled out, and you're not just seeing a laser doctor who's just offering you laser. We see this a lot, right? You know, folks go see a dermatologist or local dermatologist. Well, they happen to have a laser. Let's just see what happens. They get exhaustive laser treatment, and we really haven't. And then they come and see somebody like myself, and the workup from top to bottom in a systematic approach hasn't been done. The other thing I really want to emphasize in this forum, I really think it's critical, and this does not get enough recognition. You must get detailed hematologic evaluation. You must be screened for and surveillanced for localized intravascular coagulopathy, or LIC. The way this thing works, folks, is that when bodies have vascular malformations, our bodies are smart, right? They recognize that some malformation is present. It's not normal, it's a malformation. So the body wants to shut it down. How does it shut it down? It uses up all its own clotting factors, right? It uses them up, it uses them up, it uses them up. And so by using up all of its own clotting factors, guess what? You become at risk for bleeding. So what we have to do is we have to put the patient on blood thinner to prevent them from bleeding, which is counterintuitive, and a lot of folks don't recognize that, but it's one of the most under-evaluated and underappreciated potential complications of all vascular malformations. Not only do you have to get screened for it, but you have to be surveillanced for it regularly with frequent blood draws. So whoever you're seeing, there has to be a sort of captain of the ship that is running that entire show for you and is keeping an eye on things. You may have to be on some of their newer anticoagulation regimens that we're on. So the hematologic part is important, and again, proper imaging comprised of contrast enhanced MRI with regular use of duplex ultrasound to make sure that we're not just dealing with a port wine stain, capillary malformation. Are we dealing with some sort of underlying vascular malformation that needs to be evaluated in addition to that?
And just remember the studies done by Dr. Geronimus and Dr. Stuart Nelson and Dr. Rox Anderson, which all say lasering the lip will not prevent the overgrowth. It's a completely different entity. Tiffany has a question. Will we ever get to a stage where an ultrasound during pregnancy will pick up a port wine stain? One of the hardest things is thinking everything is okay and then finding out when the baby is born that it's there. It would have helped being able to know during pregnancy and having time to research it.
Well, I think it's critical as soon as the patient is born. That's why I get a lot of infantile, newborn consults. The key thing is to make sure that the proper diagnosis and the proper nomenclature, i.e. the proper terminology, is given right at birth. A lot of times moms, dads, they come and see me, the child is in their teenage years, and they get mad at me because by giving them the right diagnosis, I have now turned their entire world upside down. I had a young girl who had a massive venous malformation of her entire leg. They had done MR angiograms and MR venograms on this leg probably 20 times throughout the course of the lifetime of this patient. And those are exactly the wrong tests to get done. And they couldn't see anything because it was the wrong modality. And by getting one proper MRI, these things lit up like Christmas trees. And the mom and the dad were like, well, how is this possible? We went to so many centers of excellence and they told us this, and you're telling us something completely different. And we were told that he has Proteus syndrome or he has this syndrome, and they have a hemangioma that nothing needs to be done about it. And now you're telling us this is a life-threatening problem. Well, that's the reality of it. But over time, we develop a relationship, and I always say we're going to be best friends. I hope we like each other. You and I are going to be best friends going forward, because I'm not here to just do a treatment on you and send you home. I'm here to deal with all the psychosocial parameters of your malformation, the strain that it takes on your lifestyle. What is your goal? What kind of life do you want to have? And what can I do as a surgeon and interventionalist to treat this for you? Those are all important parameters that there needs to be one overlying person who is aware of all these things and can manage that for you, and you're not just getting tennis ball back and forth between various specialties. So find a go-to home person who's going to manage that for you comprehensively.
Excellent. By the way, there is one of my volunteers. She's trying to text me questions. She doesn't know I can't read them, so she has to send it through the chat that we're doing right here in the comments. She's on the board. So nope, that one's coming up, but it's coming through my phone and I can't read them.
Got it.
So Farouk wants to know. Oh, okay, that was right. Thoughts on very high D-dimer in an 8-year-old female.
Yeah.
8,421 ng over ml DDU.
Yeah, those are very high numbers. Does this young lady, does she have an underlying malformation? And the other question I really want to know is, what is the fibrinogen levels? We have to check fibrinogen levels, right? Those two are typically checked together. I would say that a D-dimer of that level, it's also an acute phase reactant, which means that it can kind of be elevated based on what some of the irritating things that can be going on in the body that causes inflammation. And so it depends on what other things this young lady is dealing with, or if there's other ailments that she is dealing with. But if it's within the setting of a vascular malformation, that's quite concerning. And I would also make sure that you get a duplex ultrasound of the extremities to make sure you rule out a deep vein thrombosis or life-threatening blood clot.
Right. This is the same mom who said the daughter was missing her femoral and
Oh yes,
heal
correct.
vein.
So I'm going to tell this to the audience, and I can't emphasize this enough. Typically speaking, patients with PIK3CA related overgrowth syndrome, such as Klippel-Trenaunay syndrome or Clove syndrome, the most life-threatening thing, and I say life-threatening because I want to emphasize that, is what we call venous thromboembolic events. Deep vein thrombosis or blood clots, which can then go to the lungs and cause death. And that's why it's so imperative, that it's so important. I'm glad you brought up the elevated D-dimer. These things need to be evaluated and looked after. That patient probably will need to be on what we call prophylactic anticoagulation.
Would that be a baby aspirin?
No, full-blown anticoagulation.
Okay.
It depends on, at a D-dimer of that level, I would put the patient on anticoagulation. Now we have what we call direct thrombin inhibitors. These doses can be modified. We're not in the era of like Coumadin and some of the other very old
Heparin,
school,
yeah.
We're much more sophisticated now. There are a variety of different options. We're learning a lot more about these in the pediatric population, and we have sort of shifted away from the kind of old school thinking. The other thing I want to emphasize in Klippel-Trenaunay syndrome is, and again, I was talking to Dr. Linda before, is that I kind of wrote the go-to algorithm for how to treat and how to approach comprehensively Klippel-Trenaunay syndrome. It's an intimidating disease because it has so many things going on, but there's a systematic approach to Klippel-Trenaunay syndrome, looking at the iliac veins, looking at pelvic venous disorders that can be associated with it. Is there an ovarian vein or gonadal vein or spermatic vein that is contributing to the internal iliac vein system? What is the what we call competence of the superficial veins that are not affected by the malformation? Where are the malformations? Are they closer to joints? Is there evidence of hemarthrosis? What's the status of the deep system? Do we have advanced pneumatic compression pumps? have we treated the other features of the malformation that have nothing to do with the malformation but are happening as a result of long-standing what we call phlebital lymphedema, which is chronic venous hypertension, which leads to the development of lymphatic malformation, lymphatic stasis, not malformation. So as you can see,
And phlebolysis.
and phlebolysis, which have to do with basically
Right.
vein, lith, stone. So stone, vein stone. That's what a phlebolysis is.
Like gallstones. but in the
Gallstones, but in the
veins.
veins, 100%, right? So a D-dimer of that level, I'm quite concerned about, and I want to make sure that there's a vascular surgical expertise that is looking at this and evaluating this for you.
I'm not sure what Eliza means. She said, is that NIC recommended for all vascular anomalies?
I think she's talking about LIC.
Oh, she put
Yeah,
NIC.
it's probably
That's
a
why I
typo.
didn't know.
It potentially can be, because when the body detects an abnormality, it wants to shut it off, be it an arteriovenous malformation or a venous malformation. The body recognizes that it's abnormal, it's an anomaly, so it's going to want to shut it off. So at the very least, getting a D-dimer and fibrinogen levels and monitoring that process at least 3 to 4 times a year, and getting regular ultrasounds, I think is critical in my opinion.
And Jill, because she does have a lot of questions, and this is her 8-year-old. Wonderful questions, Jill. You're getting me educated. You really should reach out to Dr. Nassiri. His email is in our string here. And also, I would suggest you come to our conference in October. Dr. Coletti will be there. Dr. Rosen's there. Dr. Nassiri will be there. But of course, reach out now. And as I said before, he's in Stamford, Connecticut area. Takes all insurance, so that's good. So we all know that he takes insurance. Jill's also said the fibrinogen was normal at 366.
Yeah, so that fibrinogen, in the setting of that D-dimer, that fibrinogen level needs to be kept an eye on. These are one-type snapshots, but they're very dynamic entities of the blood pattern. So don't just rest assured with just a single blood level. Make sure we get a very dedicated and a very close look at the venous system. Make sure we're not dealing with the existing deep vein thrombosis.
Patrina has a question. Specialists in New Zealand told me since my son had a normal MRI results with contrast at the age of 1, is clinically well, his risk of Sturge-Weber has dropped. Now he's nearly 4, clinically well, and developing the same as his twin. What are the chances of him developing Sturge-Weber syndrome now? He's been getting laser treatment since he was 6 months old. His left eye's been getting checked since he was 3 weeks old, and he hasn't gotten glaucoma to date.
That's wonderful. I'm happy to hear that. I'm hoping that it's limited to just the capillary malformation of the port Weinstein. But remember, there are certain things that act like fertilizer for malformations. And one of the most important things is fluctuations in the hormonal milieu and the growth hormones that develop when the patient is going through pre-adolescence, adolescence, and then obviously teenage years. The other thing for the women is obviously around the time of pregnancy, right? Lesions
Menopause.
And again, so these fluctuations, just keep an eye on things. If you notice any abnormalities or changes, you may want to repeat those MRIs. So I wouldn't be comfortable with just a 1-year-old MRI and say, okay, you're good for the rest of your life. There can be dormant lesions, and all of a sudden they kind of grow around those times because of those environmental triggers.
Well, and according to Dr. Ann Comey, our Sturge-Weber expert, if you've had a clear MRI and an EEG after age 1, it's usually okay, but the risk of glaucoma never goes away. Never. You could develop glaucoma at 75 years old from the blood vessels. It's just some are more aggressive than others.
Right.
So you never, the risk of Sturge-Weber type 2, which is the glaucoma, never goes away. Although if you get 2 clears and Dr. Comey clears you, then you shouldn't have to worry. But we did have one exception, and every time you get that outlier, everything changes. Okay, so Andy says, I have a 4-year-old son. Oh no, that's it. No. I have a 4-year-old son with a port Weinstein on the left side of his face. We've had 17 laser sessions using the V-beam. I'm wondering if it's necessary to get an MRI to check for possible Sturge-Weber, as we haven't done so yet. No symptoms or anything.
It depends on you if you have any irregularities that are obvious. Sometimes it helps. A picture is worth 1,000 words, especially to the eyes of an expert. I would say an MRI is worthwhile because sometimes what you see externally is just the tip of the iceberg. And there's really, how old was this patient, by the way?
Oh, let me just check. 4-year-old.
Yeah, so after the age of 3, I think there's no harm in getting a one-time, MRI under general anesthesia, just to make sure that you're not missing anything. I think just there's so much emphasis on laser because it's just so readily available. But I will tell you, it really is just a very sort of treating one aspect of a lot of these malformations, and there's a whole slew of things kind of deeper that really need to be evaluated. So yes, I would highly recommend an MRI one time.
So Jill's in Rhode Island, and she's gonna be making an appointment to come and see you. That was the one before. Great question from Kristen. Kristen, are you familiar with FABA and the variety of treatments, cryotherapy, sclerotherapy, medication, surgery?
We were just talking about that. Yes,
Yep.
yes. It's one of those things. There's just so much nomenclature, and there's all kinds of. We like to give titles to things sometimes, like Moya disease, for example, is another one of those things, and all that is basically what we call arterial collateralization as a result of a blockage somewhere, right? And it kind of looks like a puff of smoke, and people then wind up thinking that they have an actual disease, right? And there's a whole basis to it. But it's one of those things where it really has to do with, overgrowth patterns and underlying vascular malformations. I'm happy to answer any questions you may have specifically to that.
Thank you about that.
Yeah.
So Lindsay Bauer said, we don't have any ultrasound options that we have found in Michigan. Would you recommend MRI as an alternative? Her daughter, she's part of our network. Her daughter is 14 months old, and she has the port wine and Sturge-Weber. She has an extensive one, approximately 50% of her body that crosses the sides, GNAQ, overgrowth on her thumb.
Oh,
Very interesting.
In that case, I would strongly recommend a duplex ultrasound. Of that thumb. I think in Michigan is a big. There's some really big places there. You can go to University of Michigan and request a duplex ultrasound. I think it's very reasonable to get a duplex ultrasound. There's so much information. I would recommend for really young children under the age of 3 and 4, where I would recommend duplex actually over MRI, unless we're looking for something that is just not accessible with ultrasound. We're looking at like visceral structures or very internal. We want to look at the brain. But duplex ultrasound will give you tremendous information. It's non-invasive. Nothing is entering the body. There's no contrast exposure. There's generally no need for anesthesia. And the right physician, astute enough to understand the nuances of duplex ultrasonography and with enough expertise with malformation, can give you tons of information that will rest your mind at ease, and it can give you a good expectation of what's to come.
And remember, Lindsay, as I've been telling everyone that's on, Dr. Nassiri will be at our super clinic in October in New York City, so make sure you sign up because we already have a lot of people signing up. You get the free lodging, free ultrasound. The baby could get free laser with Dr. Geronimus. We do the free dental. We do psychotherapy, so we have a lot to offer. Okay, so let's go on, and we have Marina. Hello, my 2.5-year-old has a port wine confirmed via ultrasound by Dr. Coletti on her arm from underarm down to her palm. The back arm hasn't responded while both parts have, which isn't typical since it's further from her heart. Docs are telling us the upper arm must have a deeper malformation. Is it possible ultrasound may have missed something? And are there any lasers being researched which may have deeper penetration than the Prima, which is one of Kendall's?
Great question. Just make sure the duplex ultrasound is done by an accredited center. There are accredited centers. A lot of docs have duplex ultrasounds, or they may have an ultrasound stuff in their office, but it has to be a dedicated duplex ultrasound that takes advantage of, and I'm going to say this and I'm going to educate the audience, B-mode imaging, which is that black and white picture you see. That's B-mode imaging. Then you're going to have color flow Doppler, and then you have to have a spectral waveform analysis if there is flow detected. but there has to be what's called an accredited center that does that. We have that in our offices across 3 states. In Connecticut, I have a dedicated what's called soft tissue duplex ultrasound protocol. Everything is done in sort of a kind of a very boutique ambulatory setting. You don't have to go to some crazy hospital and deal with parking and all kinds of very difficult things. And listen, I worked at them for 11 years. I know exactly what kind of goes on and how difficult it can be. So the key thing is to bring the expertise in a very friendly environment, in an ambulatory setting where you guys can get this stuff done and get a lot of information, and believe it or not, get your treatment right there and then. This is the first time, I'm proud to say, that vascular malformations are now being brought by virtue of us really going towards a minimally invasive approach and even non-invasive, and that's a teaser for a little bit later on, we'll talk with Dr. Linda about, is that these things need not be done at these big monstrosities of institutions that are difficult to get to and reach and whatnot. So we have brought vascular malformations to a very friendly, almost spa-like ambulatory setting with really good satisfaction from patients and their families. So I would strongly recommend that you get a dedicated soft tissue duplex ultrasound, and someone who knows what they're doing is performing it, and then it's being interpreted by somebody who can interpret it properly. Furthermore, if for whatever reason ultrasound is not giving you the results and there is suspicion for a deeper entity there, then I would recommend repeating a contrast enhanced MRI, because you're right, there could very well be a more extensive, deeper lesion there. I think there was a second part to that question about laser. So this is, I think it's a good segue into us talking about the second teaser, is that what's on the horizon, folks, is not even laser, but actually that same ultrasound that we're talking about. It's not just a diagnostic tool, it is now a therapeutic modality. So I'm proud to announce that I have collaborated with the United States Food and Drug Administration. I actually sit on the United States Food and Drug Administration's I'm a special government employee for Centers for Devices and Radiological Health. And through collaboration with industry, we have secured a multi-million-dollar grant for research for using ultrasound as a therapeutic tool, right? It's called focused ultrasound, and we are using it, and we're hopeful that this is going to revolutionize the therapeutic approaches to malformations. We're going to be up and running with this clinical trial in our private practice in Darien and Stamford, we have actually 22 clinical trials going on in our private group, which is very unusual and unheard of. And we're very much focused on research. So I would say not so much deeper laser, but stay tuned. In the next month or so, we are going to be going live with our ultrasonic means of ablating tissue, and that'll do away with a lot of the embolizations and surgeries and injections and lasers and whatnot. So that is probably the most exciting news in malformations in decades.
And I've been talking about it for a year and a half, and you're
Yes.
the first person
Yeah.
that actually agreed with me and said
100%.
it's coming. So again, my board member Sharon, she keeps trying to text me through Facebook Messenger. You can't, Sharon, you have to do the string here. Look at all the questions right on our Facebook Live. It's the only way I can see the questions and answer and get your answers. So you're going all different ways, and it's not coming to me. So Tiffany said, my son's eye pressure is going up each visit, now at 20, but the optic nerve looks healthy. Can you have high eye pressure and not develop glaucoma, or is it recommended to treat for glaucoma with high pressure because he has a port wine that involves the eye?
I think it winds up at some point becoming sort of separate entities. So at some point there's enough strain on the adjacent organ that you need to kind of have your own unique approach. I think the best thing is to develop a relationship with a multidisciplinary team. I don't know where this patient is, but make sure that you have a dedicated oculoplastic surgeon and a dedicated ophthalmologist who is working under the supervision and direction of whoever it is that's running the dedicated vascular malformations program locally for you. And it needs to be a joint approach with the ophthalmologist providing dedicated information about exactly what's happening with the eye, but that has to be placed within the broader context of the malformation as a whole. And so both doctors need to educate each other, one from a specific eye standpoint and the other from the malformation standpoint. So it really needs to be a joint venture, and there needs to be excellent communication happening, ideally in the same setting between the two specialists at the same time with you present.
Right, I want to add my 2 cents because I did the booklet with Dr. Comey. And, you know, if your child, your son does have that high pressure, it is likely the Sturge-Weber type 2 glaucoma. And there's really nothing you can do to prevent it, but you can prevent any further loss of vision or deterioration by using the eye drops. Dr. Comey will be at our clinic in October in New York City doing free Sturge-Weber syndrome evaluation, so you can come and talk to her at that time as well and see Dr. Nassiri. And then Lindsay said that the University of Michigan cannot do it because you had suggested, because of her daughter's thumb being enlarged, that she gets a study done. A lot of these places, I know it
That's
blows
insane
your,
to me.
well, what's more insane is, I will tell you right now, probably 70% of the people who come through us do not have access to a multidisciplinary center.
That, to me, University of Michigan is a very renowned place. I would consider a consultation, but this is the problem, is that, you know, you may go to a place, or this is where like these kind of the problem with medicine, obviously, and this is what I said, you need a captain of the ship who's going to do all this for you, right? And if you go to a place where they are going to do the duplex ultrasound for you, right, they may not have the expertise for the malformation. So now you have to take it on your shoulders to go and first of all find out where the duplex is going to be done, get the insurance approval to get the duplex, get the proper referral to get the duplex, convince somebody to give you a script for duplex ultrasound, then take that duplex ultrasound to wherever, get the test done. It has to be the right test. You don't even know if it's going to be the right test. Then get all that information, right, and take it to your vascular anomalies expert, who may not be an expert in duplex ultrasound, and so it becomes just a headache, and my heart goes out to the patients. You're more than welcome to come see me. We'll do a duplex ultrasound for you in the office. You'll have your answer in 15 minutes. I'm more than happy to see you and get this done for you. It got a little dark there for whatever reason.
Yeah, I know,
But,
it does the sun, the changing, it comes up and down.
Oh, there you go, it's better.
Yeah, it's
But
better.
I will say, a duplex is the way to go, and you need a dedicated vascular and endovascular surgeon. The problem is there are not that many vascular surgeons that really understand malformations to the extent. I kind of an anomaly in that sense. Like I said, I would be delighted to see you. You'll have your answer in 15 minutes. I have patients that come from out of state all the time and also overseas. So we have means to accommodate you.
And right on the heels of what she's saying, Jody Lee, who's on our board, and has the daughter with the port wine that is concerned about the lip enlarging, because she has a little less than 5%, but you can see it's there, enlargement. And she's saying this is all great, and the people who can't come to you, do you have specific wording we can use to make our providers do this for our kids? Because she said that they won't do the duplex ultrasound. She's from Michigan as well.
It is a little bit insane to me. I'll be honest with you, to not be able to get a duplex ultrasound for a malformation. The problem with duplex is as follows, okay? It has to be a duplex ultrasound, right? So I'm pretty sure what's happening is you're gonna go and you're gonna ask for a duplex, right? The radiologist or whoever it is under the impression that you want the whole extremity looked at, right? They're not recognizing that you want a duplex dedicated strictly to kind of evaluate the malformation. And the problem is, yes, I have suggestions for you, but because I know the systems, right, you're gonna get so much headache and runaround, it's almost not worth your while. So it winds up being very challenging unless you have an advocate like myself who's going to be able to kind of fight the insurances. And when the radiology department calls and they're arguing that they don't want to do the study because our radiology reviewed it and decided that this is what you need, then someone has to explain to the radiologist and say, no, this is actually exactly what I need. This is the protocol. Better yet, instead of going to a radiology department, that surgeon interventionalist needs to do their own study for you. So I hear you and I understand the frustration, but I guess the best thing I can say is try to see. I have a lesion on the thumb. It's a vascular anomaly. and I want to get what's called a soft tissue duplex ultrasound to characterize the lesion. And I want a vascular specialist to evaluate it. That's the best thing. But unless this vascular specialist is a malformations expert, you're not going to get the results.
And this is why VBF is number one, because we have the experts like yourself and
Yeah.
Dr. Rosen. Because we only have 6 minutes left and we have a lot of questions, I'm gonna have to bullet through them. Julia just wants to know, is it possible that her facial port wine could be linked to her varicose veins without it being KTS?
Facial port one, does she have any features of, I would say, get it quickly, get an evaluation, like top to bottom with Klippel-Trenaunay syndrome. Make sure all elements are looked at. You're gonna have to get all those duplex ultrasound, look at your deep veins, look at your superficial veins, look at your iliac veins. Make sure that the underlying features are kind of ruled out. Do you have that contiguous, which means connected? Is the port wine stain connected from the face all the way down? Are there two separate areas? Do you have port wine stains on the legs? Have you had MRIs? Have we done LIC? There's so many things, top to bottom, systematic approach. KTS expert needs to look at it.
Now, this one from Ava is very important because I have a lot of now adult patients that never knew they had face syndrome, but they present later with aortic defects and all posterior fossa. So what kind would you recommend, like a duplex ultrasound? What kind of imaging would you recommend for someone head and neck face syndrome?
Yeah, it goes back to being the fundamental principle of dedicated soft tissue duplex ultrasound along with the proper MRI series depending on the unique features of the patient. Those are the two hallmarks. And then if there are other underlying anomalies, then we have to think about certain CAT scans that can be done looking at other entities. So it's really a kind of multifaceted approach, uniquely tailored to each patient.
Now, this is a very important question. It comes from me too. This one woman wants to come and see you, but it's a 20-month wait to get into the MGH vascular anomaly program.
Yeah.
20 months.
I'll see you next week.
Oh, I was gonna say, so for the patients who contact you,
Call Stephen Lopez from my office. We'll get you in next week.
and so
We have
you,
multiple centers. I can come to the clinic. We'll get you in. I don't care when it is. We'll get you in, and I will see you. You do not have to wait 4 months to get into whatever big entity.
thank you, that was exactly what I wanted to know. She wanted to set up an appointment, but was worried. Okay, we are down to 3 minutes, so, oh, sorry. I was trying to get these last few questions in. Oh, here we go. Mine just went blank. Alrighty, oh, there we go. Oops, let me get back here. I wanna make sure that, well, we've had quite a few. So let me make sure that I haven't missed any. I see you're scrolling. Oh, Kay Lewin, hi Kay. Kay's from the UK. Kay from the UK. I have port wine and Sturge Weber on the right side of my face. And as you know, I've been suffering from chronic pain in that area for a lot of years, as I've been to a lot of your conferences to search for an answer and have been on fentanyl till recently. For over 25 years I've come off of it, but I have no pain meds that help. I've been quite poorly the last few months. Down all my right side of my body is cold, and the feeling isn't the same as my left side of my body. I have calcifications in my head. Could it be in my legs, etc.? She has really complex Sturge Weber.
Again, what I'm missing here is that do we actually have lesions in the extremities that we're looking at as well? The one thing that, I mean, how old is this patient?
Kay,
I'm sorry if I'm asking.
well,
this.
yeah, so I think she's around 50.
Yeah,
Okay.
I would recommend if you're having peripheral, what we call neuropathy or these things, it may not be a bad idea to get what's called a duplex ultrasound of your carotid arteries. In this sort of environment, you want to make sure you have a good neurologist and a neurovascular specialist of the brain who is looking at these sort of intracranial lesions that may be happening, that may be having an impact on both your autonomic nervous system as well as your motor sensory system.
Well, FYI, there's nobody in the UK that can even help her, let alone get this level. So she can come to the conference in
Come to the
October
conference and I'd love to see
you.
you. We will do a carotid duplex ultrasound in our office in 30 minutes and we'll give you an answer immediately.
She said she's having an emergency MRI on her spine.
Consider that MRI to become an MR angiogram and have a detailed look of the brain itself as well, not just the spine.
And Jill, I think you are right. Jill said, thank you so much for this. I think Dr. Nassiri may be the missing piece to our puzzle.
Oh, you're very
And I
kind.
agree, and that's why he's here, and that's why we're very excited to have him here. So what a successful first Facebook Live.
Thank you.
I hope you enjoyed it.
Very much so.
Also, Gina does have the information for Steve Lopez. She also has the address and the number for your office. So Gina, please put that in the discussions and the chats here. Also, Sharon, we didn't get any of your questions because you didn't ask them in the Facebook Live, but feel free to write to Dr. Nassiri. Gina posted the email for him. You will see him all in October at the Super Clinic, and I might be able to talk him into bringing some of his toys to New York.
Yeah, well, stay tuned.
We'll see. Stay tuned. Thank you all, and let's see. Next month is April, and the Facebook Live guest expert will be Dr. Gregory Levitin from New York City, talking all things hemangiomas and soft tissue tumors of the head and neck area. Thank you all. Thank you, Dr. Nassiri. Stay safe and be
Very
well,
safe.
everyone.
Bye-bye.